Good evening to one and all. I, Dr. Silky Walia from Team USB, welcome you all to the very interactive diabetes talk show, The Glow Show. Diabetes, no longer a disease of predominantly rich nations, is steadily on the rise everywhere and is expected to affect approximately 125 million adults in India by 2045. What makes it even worrisome is the increasing burden of undiagnosed diabetes. Diabetes and its complications impact harshly not only the health and quality of life of the patients, but their families, finances, and the economies of nations. In an effort to address this growing health challenge, USV has committed to reducing the burden of diabetes to advance our journey towards being the diabetes care capital of the world. This unique objective, in the name of Glow Show, aims to make an important contribution to improve patient care by advancing the clinical and practice related understanding of type 2 diabetes and its consequences. And today, to drive this session, we have with us the very renowned and expert clinician, Dr. Pia Balani. Before I introduce Dr. Pia Balani, we have a brief agenda of the program. So, we'll have first the panelist view on the questions, followed by which we'll have the question and answer session wherein we can discuss all the queries. I will now take the opportunity to introduce our moderator, Dr. Pia. Dr. Pia is a consulting physician and endocrinologist from Mumbai and is currently associated with Bombay Hospital and Medical Research Center and Dr. Balani's Clinic, Kolaba, Mumbai. She is the founder member and honorary secretary of the PCOS Society of India. She is an avid author and researcher having publications in index national and international journals. Dr. Pia is a proud winner of several prestigious awards, including the Best Doctors Mumbai 2022 by Outlook magazine, America's Top Physicians by Consumer Research Council of America, Physician Recognition Award with Commendation from American Medical Association, among several other prestigious names. Welcome to you, Dr. Pia. It's a pleasure to have you as our course moderator today. I would not stand longer between you and our panelists and the audience. I invite you to please take the show ahead. Over to you, ma'am.
Uh, Thank you so much, Dr. Silky, and thank you, USV, for doing yet another edition of the Glow Show, where I feel we really get this glowing, star-studded panel talking to us this evening once again. Well, and again, what we're bringing back into focus are the sulfonylureas. Sulfonylureas, like I'm sure everybody amongst our audience and our panelists today, all of us who are using sulfonylureas are more than aware that these have been extremely important drugs in our therapeutic armamentarium for the management of diabetes. We've used them for old patients, young patients, rich patients, poor patients, alone and in combination in all sorts of formats. But no doubt, with the newer drugs that are coming onto the horizon these days, the SUs have basically taken a little bit of a backseat and have gotten a little blurred due to the questions about hypoglycemia, weight gain, etc., that have marred their reputation for a little bit. But at the same time, what we're forgetting is that SUs in themselves, where the older SUs did have problems, the modern day sulfonylureas are almost like a new class within themselves, almost, let's say. Their risk for hypos, their risk for weight gain, etc., is so much lower than what was traditionally associated with the older SUs. So as a result of that, today, I think with a little more patient monitoring, with a little more physician and patient education, this still remains for us a very, very important part of our materium for diabetes management today. And to discuss that one step further, let me introduce to you again members of our glowing panel. First, let's start with the first member of our panel today. I think we have a little bit of a lag going on. This is Dr. Alok Kanungo. He's renowned fundamental researcher in the field of diabetes, known internationally. Did his PhD from Karolinska Institute at Stockholm, Sweden. So many 100+ investigate for diabetes and immunity. He's the chairman for the Indian Consensus for Insulin Therapy of Type 1 Diabetes. Welcome, Dr. Kanungo, to this panel today we are to have you here with us today.
Thank you, Pia.
And then introducing our second panelist for the evening. That is Dr. Bantwal. Dr. Bantwal basically is professor and head of the Department of Endocrinology at the St. John's Medical College Hospital in Bangalore. He's the immediate past president of the ESI in 2021, and prior to that has, of course, held so many multiple positions. He will take up the entire evening of my reading if I start reading all of those. Has received so many awards, the Nada Gowda Oration Award, the 2014 RSSDI Oration Award again, Dr. Sunil Kumar Basu Oration Award, principal investigator in more than 80 trials, 100 plus publications to his credit. Dr. Bandwal, a warm good evening and welcome to you as well on the panel for today. And our third panelist for the evening, Dr. Kaushik Pandit, is a consultant endocrinologist and diabetologist from Fortis Medical Center, Bellevue, from Calcutta, also affiliated as a research scientist in the Department of Endocrine at JIPMER, Calcutta, with several awards, the Albert Reynolds Travel Fellowship from the European Foundation for the Study of Diabetes, Best Reviewer Abroad from the IJM in the Endocrine Society of India National Conference of 2012. He has extreme research experience and trained additionally alongside with clinical epidemiology, genetics, training and certification on the ICH GCP guidelines and from multiple global institutions. Dr. Pandit, again, welcome and good evening to you as well.
Thank you very much.
All right. So moving on without wasting a minute over here, let's jump into our question answer panel for opinions from our esteemed panelists for today. Let's get to the first question. Dr. Pandit, we will address that to you right now since we have ended the last introduction with you. So basically, just in this ADA, which has just recently terminated a few days ago at New Orleans, in the ADA 2022, that is the scientific sessions, suggested that there were 44.3% of patients with diabetes prevalence in India. So let me just give you a background on this. This was a retrospective analysis. More than 225,000 patients studied, were screened basically for diabetes, of which more than 1 lakh, 44.3%, showed that they had diabetes. And that is a mind-boggling figure. Even more surprising, 17.8% had diabetes in the age group of less than 35, 13.3% in the age group of less than 30. Now, what my question is to Dr. Pandit, today the recommendations of the ADAR to start screening at the age of 35, the ICMR for that matter recommends screening roughly at the age of 30 for our population today. Looking at this number, this particular abstract this analysis that was submitted, what do you think, Dr. Pandit? Is this as mind-boggling to you as we are all feeling? Should we be maybe screening earlier? Should we be basically doing a blood glucose for every single patient that steps into our clinics? How do we overcome this issue?
Thank you. Fortunately, I was part of that One Nation, One Day, 1 million test.
Yes.
And it is a stupendous effort by RSSDI to pick up on the go people and test them. And it is really, worrisome that it shows such a high prevalence of diabetes.
True.
It is true that it has picked up a huge number of diabetes, and worrisome more is that many of them even do not know that they had diabetes. But you must also remember that the data is slightly skewed in the sense that it's clinic based and people who are getting into the clinic. So there is a fair amount of volunteer bias in the study.
True.
That actually jacks up the number, but no doubt, without any doubt, that India is progressing very fast so far as diabetes prevalence is concerned, and we should be very careful about it. We know that patients from South Asian countries, because of their genetic predisposition, which has not been unraveled to its entirety, coupled with the recent lifestyle changes that has come into the country after our independence, which probably is borrowed from the West, has given us this new disease of new pattern of diseases, which has overshadowed the infectious diseases that was really roost before the independence. So after the societal socioeconomic changes that has been ushered in the country, and with the background genetics, it is certainly not a very welcome change that we as physicians see. The most worrisome point is that large percentage of people are not even aware that they do have diabetes, and actually here we need to do something about it. We have known about the adage that 50% of people, of all people with diabetes, know they have got diabetes. 25% of people, 50% of them, go for treatment. 50% of them are under good control. So that makes a very minority of people who are getting the target to reduce the problems associated with diabetes, the complications.
Right.
So, if we are to do a favor to the country, if we are to do a good service to the country, the first thing that we need to do, we try to get them young, in the sense that, going even beyond the metaphor, we really have to catch them young, in the young age of diabetes, so that I can start treating them, so that I can make them aware that these are the problems associated with diabetes, and that actually would help them in the long run. I'm not sure whether you should make blood glucose as the fifth vital sign, but I'm absolutely sure that it is an extremely positive step by the government of India, if taken, would be a very welcome to the fraternity of physicians to pick up more and more diabetes, to get them under the umbrella of treatment.
So, Dr. Pandit, with that kind of thing, do you think that, I mean, I know I'm taking the discussion to metformin. Do you think we are underusing metformin today for our pre diabetic population to a great deal, just
Um,
letting them go?
I mean,
I mean,
I,
what's
I
your
mean,
opinion on that?
this may not be minuted, but it is true that all of us are experiencing, and I mean over usage, or the suggestion for over usage of various other anti-hyperglycemic agents, especially the newer ones, and which are actually pitted against the metformin. It is also important to believe that the one which has been in the use for the last 50 years or so, or more than 50 years, has proved to be a very useful addition in the armamentarium of the physicians for maintaining glucose, especially in the early phase of the diabetes, who are not at a very high risk of cardiovascular disease, who forms the majority of people with diabetes. And
Yes.
there it's a wonder drug, no doubt about that, with no extra risk of hypoglycemia, with no extra risk of weight gain, and blah blah blah. So that way, certainly metformin would be a very welcome addition for a large majority of people with diabetes, irrespective of what the big pharma industry is trying to
True.
let us understand.
Right. Yes. From that perspective, old is gold. There's no doubt about that. Let's move on to our next question, and this I will address to Dr. Kanungo. Now, as Dr. Kaushik also mentioned, that this ADA's 2022 scientific session reported that in one of the data submitted over there, 10% of individuals unaware of their diabetes status. What do you think this means for us? I mean, what should our general approach to be? Should we be screening families at large? How should we be approaching this where people are not even aware?
Pia, this is a very important question. We always follow Western guidelines, ADA guidelines, and they have reduced it from 45 years to 35 years. And they think that by that 80 million new diabetics, pre-diabetics, they have found out. In our population also, as Kausik told, it is very important that our age set is less. Age at which we target our preventive program is much younger than the Western population. Here, 20 to 30 years of young boys and girls are now prone to diabetes, or pre-diabetes at least. And we all know that diabetes takes 10 years to develop, and that is the window where we can interfere and prevent it. So diabetes prevention program has taken a lot of importance, and many of us are practicing that. The question is, many symptoms appear in the families of diabetic children where you can prevent it. First, let us catch the children of diabetic families being a genetic disorder manifested by environmental onslaught. The first target should be children of diabetic families. Test them regularly after 20 years of age or with the earliest symptom. Glucose is one of the parameters. Other things should be also taken note of, and those who can financially stable can be done with C peptide also. So we know how the beta cells are working, and metformin introduction at that stage is of very good importance. Of course, the studies have shown that lifestyle modification and metformin have almost parallel action, but metformin certainly reduces the insulin resistance by the time beta cells are still active. When beta cells are still active and not in the verge of getting type 2 diabetes, if you take care of insulin resistance at that time by doing regular exercise, diet control, and addition of metformin, you do immense service and prevent a lot of them or delay a lot of them to get diabetes. So that is what I think. Early initiation of lifestyle modification, diet modification, and metformin in selected cases where you are finding it is IFG, it is IGT. In those cases, metformin plays wonderful role, and that is not the thing. You get equivalent, almost half percentage of complications like retinopathy and other things in pre-diabetic stages. So it can prevent those things. So metformin is a safe drug given to non-diabetics, given to PCOS, and so side effects are much less. And as Kausik has told, 50 years have passed with a good traditional record of metformin. So in my practice, I use a lot of metformin for preventive. I run a DPP program, diabetes prevention program, in which we have lifestyle counselors, we have modulating counselors, we have dietitians, and I personally supervise it. And addition of metformin in susceptible cases really helps and does wonders. So I think metformin and lifestyle modification has a tremendous role in preventing these pre-diabetics to go to diabetics.
So, Dr. Kanungo, if you find, let's say, a pre-diabetic, you said we should start screening the children of, of diabetic families. How early do you initiate metformin? If you have a young 10-year-old kid, let's say with an A1C of 5.9, a little obese, a little acanthosis, how young do you start them off on metformin then, sir?
Not so young. After 18, I will start.
After
After
18 years.
18 or 20, I will start. Not so
Right.
young. I don't know it is type 2 diabetes in young or not. It can be, there are plenty of cases of type 2 diabetes in young.
Yes.
Metformin will not be bad for them. But
Yes.
for 10 years child, 12 years child, lifestyle modification, educating the parents is much more important than giving any pharmacotherapy. I will
Fair
not
enough.
start there.
Correct. Fair enough, sir. All right. Let's move over to our next question for the evening then. Dr. Bantwal, for you, this one. Now, we have been having more and more use of the AGP, and time in range now has become an emerging concept for managing diabetes control. So, right now, what is your opinion? So far, do you feel that the fasting, PP, HbA1c, which are our traditional glycemic triad, is that something we still pay attention to? Do you always look for a time in range? How practical is this really? How do you use it in practice?
Well, so yeah, I think that's a good question. Uh, I have been using this time in range, especially when I find there is a mismatch between the SMBG readings and the HbA1c. So patient comes to me and tells me my blood glucose are this numbers and the HbA1c is showing 9.5%. So that's a time I feel no, I think I must look for something more, and that is the time in range. Yeah. So another place where I actually look into is, suppose somebody is complaining of hypoglycemia but having an HbA1c of 10%. So that's another time also when I want to see what are the glucose excursions, how much high it is going and how much low it's also coming. So you could still have somebody having an A1C of 9% and still getting hypoglycemia. That's still possible.
Absolutely.
So these are some instances where actually I will go for that. Yes, I think we must use it judiciously. We must use it more often also. See, another place, once again, the patients, you have, say, a type 1 diabetes who is, he wants to know which food will increase my glycemic excursions, how much. So they actually, in fact, they ask me, there is an entity known as this, shall I use this? Yes, I'll tell yes. So you will
Yes.
know that the pre-meals are this much, my post-meals are this much for that particular food. You roughly get an idea how much glucose excursions can happen with that particular food. So that's another place, not necessarily in type 1, it can even be for type 2. So, okay, I have a few patients who do this and tell, if I eat an apple, it increases by only 30. If I eat, say, upma, it is increasing by around 80. So they're coming back to me and telling. So you get a rough idea how much the glycemic index is for that particular individual, how much it's going up and down. So I
Right.
think we should use, there is a place for use in this. And of course, even in pregnancy, maybe. So suppose you find that the abdominal circumference is more than 75th centile, but the glucose readings, what she does by the SMBGs are normal. That's another time when actually I will actually look into this and find where is it going up so that we could target those aspects. So yes, there is a role, use it judiciously.
So, Dr. Bantwal, having said that, do you find that sometimes there could be errors and there's a mismatch sometimes between the AGP and the either the home monitoring or lab monitoring? Does that happen often with you also as well?
Less often, but it can happen. So it does happen that you may find an abnormality. More so, see, when you find that the postprandial excursions, no, there is a mismatch. See, suppose the patient is having a drop in the glucose very
Yeah.
much.
Yeah.
That's not reflected so much in the AGP. The patient is
Correct.
getting the symptoms, but the AGP showing the normal value still because it's
Right.
taking some more time, and that's because we are measuring the interstitial fluid also. So yes, so
Correct.
we do get mismatches also, but keeping all those things in mind, I think it's still a good tool in some circumstances.
Right. No, fair enough. And I find it very, very useful when I'm, for example, initiating insulin. Just helps us to rapidly titrate patients, get them under control. And I agree, it improves patient engagement because even rather than getting us the data that the apple increases it by so much, the patient is realizing what impact lifestyle is having or taking medications is having. So I agree, it empowers the patient as well in terms of getting engaged with their own care. So fair enough. Do any of our other panelists have opinions on using nowadays this kind of digital technology for management of their patients? Dr. Pandit, what about you? Any, or Dr. Kanungo, if you want to tell us about your experience?
Regarding this sulfonylurea use, I have highest experience in glimepiride. I was using a lot of glipizide initially, and then glimepiride came, and that opened up the Pandora's box. 24 hours working, safe, no side effect. The question is here, you have a very good vehicle, a Mercedes. Driver has to be good. Otherwise, it will crash anywhere you like. The speed of the vehicle and the quality of the vehicle is not considered if the driver in the seat is not adequate and he doesn't know where to give clutch and where to give brake. So, glimepiride is one such drug. With zero point 0.5 to 1 and even 2, you are very safe. I never go beyond 2 because I
I
don't
see.
believe high dose of glimepiride, like people say, up to 8 milligram. I don't know. There is no point in whipping a tired horse, no point
Right.
in squeezing the beta cells. So, if it is not working in 2 milligram, I think it is not working and I add other drugs. But by starting with in a blood glucose of fasting 250 and postprandial 350, and the patient is not willing to take insulin, if I start glimepiride 2 milligram with metformin alone, without gliptins, sugar comes down to a very good effect, and within 1 month, I have to reduce the dose to zero point 0.5 milligram glimepiride with metformin. So,
Right.
as regards euglycemia is concerned, glimepiride is one of the best molecule to reduce blood glucose, particularly in our setup where costly drugs are really difficult to prescribe and avail. So I
Right.
stand by this, and this is my opinion.
Right.
I guess you are interested to know about the TIR, time in range.
Yes, please, sir.
Yeah, yeah, that's an very useful addition to the our usual treatment schedule. But as Ganpati had said, that it need not be overused in the sense that every Tom, Dick, and Harry or every person who coming into you for your consultation need not be given the time in range. It needs to be used judiciously in the sense that people whose the standard fasting pp and glycated hemoglobin are not matching with his or her explanations, or you expect or the person is experiencing a lot of hypoglycemia despite having a very high glycated hemoglobin. That probably shows that the person is doing something good or bad, or the person is having a brittle diabetes. And the most useful addition for TIR would be in people, especially who have got hypoglycemia unawareness, where the
Right.
person is going into undocumented hypoglycemia or unknown hypoglycemia, which would be a useful addition in managing his glycemic control for every 24 hours. How to change the medication from morning to night or midday or whatever you want to, like, according to the pharmacodynamics of a drug.
Right. Fair enough. All right. I have the next question then for Dr. Kanungo. Thank you, everybody, for your opinions on this, the digital move that we are experiencing today with diabetes management as well. Dr. Kanungo, for you, the question now is, when we are talking about flexibility of a drug, we are talking about using a drug that's safe, that's efficacious, that's convenient, that patients are compliant with, that is combinable, and which you can titrate up and down as well. So, in terms of flexibility, you expressed yourself in terms of flexibility of modern sulfonylureas. What would you say in terms of that part? I mean, do you apply it routinely to all your patients? How do you choose?
This is very simple. The person sitting in front of you, his profile, his obese or lean, his blood glucose fasting values, his glycosylated hemoglobin values, and his pores. Everything is taken into consideration. Not only that, the scientific theories are not applied every time, and time in range is a new concept. We have been monitoring it by 7-point blood glucose levels, and time in range has been even today in most part of the country is there. I also do CGMS, time in range and other things in selected cases, but as you can go slow. That is the most important part of the therapy. If the physician or the diabetologist is going slow, and that slowness is not for 3 months, 6 months, it is within 1 month, you can fairly well know that the drug is responding or not, and any other drug is accepted. And many times we are combining a low dose of glimepiride with vildagliptin and metformin combination. So that makes the program problem much better solved. And
Yes.
vildagliptin, metformin, and low dose of glimepiride makes a very effective concussion for reducing the blood glucose. So I think it is very flexible. It is all depends on you, and you can always control the blood glucose. And this here I want to say, we have many times stamp people as secondary sulfonylurea failure, but they are actually LADAs. They are in fact slow onset type 1 diabetes or LADAs. Without investigating them for C peptide and antibody marker, we should not stamp them as secondary sulfonylurea failure. There are many LADAs respond to sulfonylurea for 6 years and then they require insulin. So these
Right.
cases should also be kept in mind.
Right, absolutely. That's a good point. Dr. Pandit, for you, with regards to SUs now, SUs, I mean, everybody, physicians, patients, everybody alike associates SUs with this scare of hypoglycemia. What is your opinion on this effect of sulfonylureas?
Well, the street noise is created not by the patients or physicians. Street noise is created by the pharma industry itself. There are
Well put.
vested interests in the pharma industry who would like to kill the dog glimepiride by giving it a bad name. But we must also should not forget that as a treating physician, as Dr. Kanunga has said, that not everybody need to ride the Mercedes.
Right.
We must not forget what our goals are. We must not forget it is the patient, in contrast to the Western population, has to pay from his or her own pocket and have to reach our primary target of goal of glycemic control.
Yes.
And while doing so, the sulfonylurea has earned a bad name so far as causing more amount of hypoglycemia, which is true, and more amount of major adverse cardiovascular events or MACE, as has been popularized by other agents in the field. It is true that hypoglycemia is more common with sulfonylureas, but we must also remember that side effects are intimately built in with the effect. So the one which is likely to give a lot of good control of sugar is also likely to push the patients who are prone to develop hypoglycemia to a range of hypoglycemia. What is more important that we have to choose our patients judiciously. We must not give sulfonylureas to people who are prone to develop hypoglycemia and, or more importantly, have got hypoglycemia unawareness. And also socially, we must accept that people who are living alone, they cannot care for hypoglycemia in their own home. So in those special circumstances, barring those special circumstances, which are, I must say once again, are rare, the majority of population of this country who are young and who would not like to spend a fortune for achieving good glycemic control are good candidates for sulfonylureas. In this regard, may I, with your kind permission, can I share one publication? Can
Please
I
go ahead.
share? I'll just a second. Oh, I'm sorry that the permission is denied. Anyway, I'll just read it out for you.
Sure, sir.
I mean, this is our group has published in diabetes and vascular disease research in the year 2020 November, where we have done an indirect comparison of cardiovascular safety of glimepiride, an indirect meta-analysis, and getting the data from the Carolina and Carmenilla study, where linagliptin and placebo and linagliptin and glimepiride have been done. And there, in this particular study, our conclusion was cardiovascular safety of glimepiride is reassuring and may help patients with type 2 diabetes world over to avail the benefit of this affordable, efficacious medication, because the risk of hypoglycemia is equal to placebo, nothing more than that. So that way, we are sort of comforted in the fact. I mean, this is not made of something which is made out of something else. I mean, it is
Yes.
pure data, published
Right.
data, and the network meta-analysis has shown that it is no more hypoglycemic, causing hypoglycemia than placebo. So that way, and that way, its cardiovascular safety is sort of established by, of course, by this indirect method. So if we think that we have to achieve good glycemic control in an easier way, in a much cheaper way, with good bit of flexibility, there is no alternative to glimepiride. Let's accept this fact.
Right. Absolutely. That was crystal clear. And in fact, as the question also mentioned, the recent ADA 2022, the study that was recently published there also, that also basically showed that with sulfonylurea's risk of hypos was no hypos in 74%, with 26% of people just experiencing like a grade 1 hypo, very few severe hypos if at all. So all of the newer studies also, yours included, sir, that you've just read out, all saying that the risk of hypos is actually less with the modern day sulfonylureas such as glimepiride. Thank you, sir, on that also as well. Dr. Kanungo, we'll come back to you now for a question over here that for patients who come to us with a very high A1C, like a 10 plus or so, we usually talk about recommending insulin. However, patients, obviously, today, I think even you and I, if today we had a choice of insulin, well, we are not going to accept it very easily. How then would you place the low dose modern FUs to manage such patients who, let's say, are refusing insulin?
This is a very important question, Pia. But I try my best to convince the patients, counsel the patient to take at least insulin for a month or two to reduce the glucotoxicity.
Yes.
Failing which, I pick up a low dose of sulfonyl glimepiride with metformin, add one gliptin and a SGLT2 inhibitor to that. So with that, I find we get the right result. Now, vildagliptin with a dapagliflozin combination has come to the market. That is a wonder drug now. After the product, cost of dapagliflozin came down, and the market is now flooded with SGLT2 inhibitors,
Yes.
and glimepiride and metformin still remain in the use in such high value targets who are not willing for insulin. How many people are still using glibenclamide in India? If you have the statistics, millions are still using downhill or glibenclamide in India. Nobody
Yes.
prescribes them. The pharmacist prescribes, they are taking it and they are well controlled.
Yes.
So let us not blame sulfonylureas for not so important faults of theirs. They can be all modified. As Kausik has told, they are safe in cardiovascular, and other Carolina and Carmelina trial has proved that all is needed is the right dose prescription. I have 1.5 lakh patients are on glimepiride and metformin combination, regularly registered, data maintained. So I don't find so many heart attacks or anything in them. They slowly, as any diabetic, they slowly progress to nephropathy and all, and we change the drug. And that is no way prevented me from prescribing glimepiride and metformin or alone either of the drugs in combination.
Fair enough. Dr. Bantwal, coming to you then next. Well, we know about this concept of the legacy effect. Now, in your opinion, when we are trying to kind of prevent this legacy effect from happening, how early, how fast is good? What is your opinion on this particular phenomenon?
Yeah, I think the concept of the legacy or the memory effect came from the DCCT EDIC trial in type 1, where they found that the patients with type 1, even after the A1C went up, the intensive arm group, and the conventional who had an A1C of around 9 reached 8, and the intensive who had 7 reached 8, both had the same A1C. But then the intensive arm group continued to reap the benefits. At that time, they called this as the memory effect. And the similar thing was found in type 2 diabetics in the UKPDS, once again, as the follow up studies of UKPDS. And there, this concept of legacy effect came. The same thing happened there. 7 and 7.9, both of them reached the same A1C. And you find that the microvascular complications continue to be there in the group on the intensive arm. So I think in our Indian terms, we call it as a karma effect. You do good, you reap the benefits. So it's
Yes.
like that. This should start as early as possible, because you should hit hard from the beginning. You should not say, okay, give me 3 months time. The patient tells, give me 3 months time, please don't do. I'm very clear in that. I tell them, even if they are overweight, whatever, I'll put you on the medications, let the A1C come down, then I'll down titrate and even stop it. That's fine, but I'll not allow them to go. Because sometimes you do require to bring down the glucotoxicity, as Dr. Kanugo was telling, that you just bring it down. It could be a little bit difficult with just diet and exercise. So at that time, you should intervene, bring the glucose levels normal. Now your own insulin machinery is acting well, and that's sufficient to produce enough insulin and to bring down the blood glucose levels. The reason is this: if you don't control it immediately, see, these microvascular complications are because of the mutations of the mitochondrial genes, and as you know that they don't have introns, they only have exons. No intrusions are not there, and that's the reason they are more prone for these mutations, and these mutations persist, and that's the reason this continue to be there. So that's the reason hit her early from the beginning itself. And also to add on the what about macrovascular complications? The follow-up studies did say that you control it from the beginning for the glycemia, it is going to help you for reducing the macrovascular complications, but it's taking a longer time. That's all. But you're going to get the benefits of that also. So I think hit early from the beginning, see that the blood glucose levels are very well controlled. Then, if you want, you can down titrate it, but don't give the time of 3 months, 6 months. Let me try, let me try. No, that shouldn't be given.
Fair enough. But one dilemma I face, Dr. Bantwal, nowadays with this whole social media, so much talk about diabetes reversal, right? So when patients are coming to me with this 7.5, 7.88%, all of them will say, you are not giving us a chance for this diabetes reversal. Give me that time. And then if you don't give them sometimes. And so I will explain to them about this whole legacy effect and the complications that have already started behind the scenes. But then they feel that this doctor does not believe enough in the concept of diabetes reversal, which they are reading about, bombarded with everywhere. How do you manage this kind of social media kind of overhype then?
Yeah, this is a very important question. Every day I get these type of
Yeah,
patients. I mean, a newly diagnosed, he's overweight. Yeah, then there is a chance, but not somebody who's having an osmotic symptoms, etc. There, I will not listen to him. Please follow this. This is a standard way by which we have to monitor. I mean, manage diabetes. You bring down the blood glucose levels to normal, then you do whatever you want. So I tell them this. See, even in the so-called diabetes reversal programs, there are many places where they still continue to give the medications. It's not that they're this one. They they may not be on an SU or something like that. They will down titrate it. They will usually be on a metformin and an SU, or sometimes they'll be on a glitazone, etc. So they are still on a medicine, but not the ones which are producing hyperglycemia. They'll tell, no, I'll give you an SU for just 2 weeks. It'll come down, and then I'll stop it. So like that, they counsel and tell them. So here also the same thing. I tell them, bring it to normal, then I listen to you. Till it comes to normal, you have to listen to me. I think 99 out of 100 will listen. There are exceptions. Not all patients are the same. They'll go for another person who will agree to that. So
right.
otherwise, I think it's fine if you tell them the natural history.
Right. Dr. Pandit, let me take your opinion on this whole diabetes reversal process also, because that has become the mantra of the day. What is your opinion on that? Are patients coming to you? How are you counseling them? Are you doing programs of this nature in your own clinic also as well?
I don't run any program like that in our clinic. But
Yes.
what is important, we have to manage the social media storm.
Yes.
And the social media storm is there not for anything. It has got an consumer bias toward it. It has
Yes.
got a commercial bias toward it. And it's not done by somebody without any conflict of interest. Of course, there are.
Yeah.
And at that point, we must also appreciate the fact that whoever is entering our clinic are not the right candidate for that one. It is true
Yes.
that many of them would be a good candidate for diabetes reversal, if it at all, if you can use the word. But I must also tell you that I work in an institution where the bariatric surgery is extremely common, and people who have, so to say, reversal of diabetes after 10 years, they are stepping into my clinic with type 2 diabetes. So it is not universal. It is not something which is once it is done, you can just fit and forget. So it is important that people who have had, so to say, reversal we'll have to maintain a reasonable lifestyle, especially in terms of weight control. There probably it will be useful. And in people who have got a sort of moderately advanced disease, then it will be absolutely not only useless, it will be dangerous. As Dr. Ganpati had said, that not everybody would fit the bill.
Yes.
So you have to let them understand. And people is unfortunate. We are unfortunate lot, me, Dr. Ganpati, and Dr. Kanungo, that we get to see at the fag end of the story of diabetes. We
Right?
rarely see people who have been recently diagnosed. So people who are
Yes.
having diabetes for more than 10 years and having a failure to almost most of the drugs, they
Yeah.
surely would not be a candidate for diabetes reversal. And we, as Dr. Ganpati has said, on the very first day, must dispel this myth that this will be useful for him or her. In fact, it will be more dangerous if the person goes for such surgical intervention.
Correct. I agree that I feel with social media, this whole diabetes reversal, what they are failing to inform people is that monitoring continuously in the future is required. So once they've come into their normal this, I think that's where patients are forgetting that they still remain at risk, that beta cell failure is going to continue to happen as well, and that this might just very, very likely recur in the future again. So that I think is where the counseling has to happen in a that kind of education is very important with the patients also as well. Dr. Kanungo, your opinion on this whole, on these
I fully
pro
agree with
social
Dr. Ganapati and Kausik. They're very correct. And I don't agree with the term diabetes reversal. It can be diabetes remission. It has two components. One is genic, the other is environment. Environment can be controlled. We are not going to take away genetic makeup or genetic background of the patient. He still remains prone to get back the diabetes. Now the question has become diabetes re-reversal. You reduce 15 kgs, come down to a certain stage, your insulin requirement comes down. But still, after that, you live. You were a prisoner of doctors. Now you have become a prisoner of lifestyle managers. They do so much of exercise, diet, and all those things. So you are remaining a prisoner somewhere or other. And
right.
your life is marred. What are you living for? You are you living to take 37 grams of this peanut and that is 56 grams of this keto diet? All these things are, I don't agree with that. Live happily, live, eat happily, take healthy fat, take high protein, reduce carbohydrate, do a lot of exercise, and whatever is achieved is achieved. You lead a
Right.
normal life. You don't need to
Right.
reverse diabetes. So
Doctor,
remission can be something. Remission.
go ahead. Go ahead.
Myself was a remission case. I was
I say,
taking 80 units of insulin, 40
oh my,
40,
wow.
and empagliflozin, linagliptin, all those things I was taking. This COVID time, my son and daughter came from abroad. They stayed at home, made me do exercise regularly, and a
Yeah.
16-hour this diet, that
IF, intermittent
intermittent
fasting.
fasting, and
Right.
I lost 12 kgs. My
Oh
insulin
my,
requirement came down from 80 units to 12 units. Now I
oh my
am
God.
at 16 units out
Right.
of 80 units. I got
Right.
the result, but remission is not there. Means reversal is not there. It's not for us. As Dr. Ganapati told, it is young, initially treated, or just beginning without any macrovascular or microvascular complication. You can consider that, not for others. Kausik also told the same thing.
Right. Dr. Bantwal, your quick opinion on these diets, like we just heard about the keto diet or this IF. What are you telling your patients about these? Just in a very brief for us.
So many of them come and ask me about these diets. And as you know, there are some 18 to 22 types of various type of diets. The
Yes.
problem with this diet is nobody can follow this diet for a long time.
Same.
It's
Correct.
usually a maximum of 6 months to a maximum 1 year you can follow that. Afterwards, it's not palatable. It's not possible for anybody. So the best thing actually would be in this type of patient is, so they go for a keto, then go for a paleo, then go for that, what is that, 16-hour fast, intermittent fasting. You keep on doing this rotation, then it is
Yes.
possible. Otherwise, the same diet is impossible. Nobody can follow that. So I think when once you put them on this diet, that diet, this diet, they'll follow that for 6 months, stop it. Once again the glucose goes up, go back to the other diets. So that's what I tell them. So 18 to 22 diets, nobody can follow them for a long time.
Right. I guess the name of the game has to be a sustainable diet. And kudos to you, Dr. Kanungo, for having lost all that. I mean, you're a living example of lifestyle change then, and that's great for this audience. Dr. Pandit, your quick word about these diets again in general. What do you advise your patients, and what is your opinion?
I would completely agree with Ganpati that it
Yeah.
is really, and it is, I must say, in metaphorical term, unpalatable truth that people can continue having the same diet for years on together. It's not possible.
Yeah.
And while
Yes.
treating a patient, we must not forget that they're just like me and you, just another human
Yeah.
being, having the same sort of inclinations, uh, likes and dislikes. And it initially starts with 7 days rigorous schedule, then one cheat day, then 6 days, and then gradually the cheat days increases and it falls
Yeah.
flat after 4 or 5 months. It's very
Right.
difficult. Rather,
Yeah.
it is much more prudent if we, as both Dr. Ganpati and Dr. Kananga said, that it has to be built in into the system that
Yes.
you do this, that, and a lot of exercise. Probably that will be helpful. And in fact,
Yes.
as a publication in recent NEJM had shown that the intermittent fasting, it does reduce the weight to some extent,
Yeah.
but has got little effect on the glycemic control. And so that
Right.
way, I mean, when and as all of us practice empathetic treatment in the sense that we have to treat patients just like ourselves. So if we cannot
Yes.
follow the same that we are advising, probably it is better to refrain from advocating such uh,
Right.
I mean fancy things coming out of the different worlds.
Right.
Yeah,
True
one
words.
thing I
True words.
want to
Yes, sir.
Pia, one thing, just 1 minute. Uh, all of us know mother's recipe is the best food. We have
Yeah.
liked it from childhood, and we always we crave for that food. Let us not leave
Right.
that food. Let us not forget that food. Reduce the
Correct.
quantity as your age and work demands. Reduce the carbohydrate and continue to have those spices, those everything that a mother fed you from childhood. And that is the best diet for diabetics. There is nothing called diabetic diet. It is the
Right.
quantity that matters, not the quality. So quantity has to be controlled. You can eat
Right.
everything, still you can maintain a healthy pattern,
Right.
better glycemic thing.
Right. Those are true gems of words, sir, also. We'll quickly run through our last case. Dr. Bantwal, I'll take your opinion on this one first. So, this we're talking about a 25-year-old young woman who's come to you for diabetes care. She's got a past medical history of IBS, basically, probably telling us that metformin not so suitable. Her mom and sis were both diagnosed with diabetes in their 20s. And the patient thinks that they're taking insulin right now. Father, no diabetes on exam, a BMI of 23, blood pressure is good, pulse 74, not in acute distress, no signs of insulin resistance either. Everything else is normal, thyroid too. Now her A1C is 7.4, random glucose is 188, and she's had a small breakfast today. In terms of diabetes, what is your diagnosis? We just mentioned a little earlier about diabetes in young, about all the various kinds of forms it comes in today. How would you assess and evaluate and manage this patient? Dr. Bantwal, first over to you.
Thank you. Yeah, this is a very interesting case. Now, since the mother and the sisters are taking insulin, probably taking insulin, well, I would like to keep this patient also as having a type 1 diabetes. But of course, she does not have a history of, say, insulin resistance. So that's another clue you are giving. Telling once again,
True.
probably we are not dealing with type 2 diabetes in the young, or the so called young. So
Correct.
keeping type 1, so probably in her case, I may get a GAD and a C peptide just to see what's the reserve of insulin. and I will know whether she's type 1 or not. And if it turns out to be that the GAD is negative and she has a fairly good reserve, then probably I will work up for the parents also, the mother and the sister, and prove
Yes.
that probably they are also not so-called quote unquote type 1. Probably they are a maturity onset diabetes in the young, perhaps like that. So we require a little more information, but I think this is how I'll approach. First thing is I will keep type 1 as my first uh, diagnosis. The
So yeah.
reason being mother and sisters have it. But then
Yes.
I will also like to keep the other things like maturity onset, because the she's having not very high blood glucose levels. Usual common
Correct.
garden type 1 will be they have a very high levels of blood glucose. So that's another.
Yes.
And the third thing, not so much here where Dr. Alok Kalunuga comes. Yeah, if they have in addition pain abdomen and steatorrhea, these type of things, though she has a history of IBS, if she has a pain abdomen, steatorrhea, etc., I would like to keep even a pancreatic diabetes or an FCPD in mind also. So with these three things, I would actually like to keep. And if it is type
Right.
1, naturally, I will be putting around only insulin. And if it is
Yes.
so-called quote unquote Modi, then I will actually put her on a small dose of glimepiride because they're super sensitive to SUs. And of course, if
Yes.
they are the other varieties where I may do an X-ray and find whether they have any calcifications, etc., then probably a mixed one. I may put them on a small dose of glimepiride. If they are not tolerating, etc., then finally I may put them on insulin also. So this is how I will approach to this patient.
Approach them. So yes, thank you, Dr. Bantwal. That was an excellent management. I mean, assessment of the differential diagnosis. We have a possibility of type 1. We have a possibility of MODI that we must keep in mind. Pancreatic diabetes also. So yet, I think the room is open in terms of how this workup is going to progress and accordingly make the decide the management as well. I know Dr. Bantwal has to go. So as a result, Dr. Bantwal, if you need to sign out, thank you so very much. In the meantime, Dr. Bantwal, before we move on from you, since I don't want to then have you this, any last words? The goal of the show today was about SUs in your practice. Any final few words before I let you go, sir?
See, we have been using SUs from time immemorial. I think when we were students, we knew only two drugs: SUs, metformin, and insulin.
Correct.
Patients were doing well, and they continued to live, and they didn't have much complications. And as Dr. Alok Kalnugo told, we were using only glibenclamide at the time, and patients did well. So it's not that it is an outdated thing. The usage probably has come down from number one position to maybe number three. That's because of the hypoglycemia. But then if you use a low dose SUs, and if you use it judiciously, we can actually prevent these things also. The so-called
Correct.
hypoglycemias happen initially. What happens when they come to you with a high blood glucose? They are on a higher dose, but you must tell them, educate them that see, once the blood glucose comes down, your requirement comes down. It could be possible they may be even off that also, or they may be requiring a
Yes.
very small dose. So this is a mistake they do. They don't come back, they get with hypoglycemia, and everything has been blamed for that. So
Correct.
then the other question came, they didn't have a cardiovascular, what do you call, study, but at least the Carolina told it is also CV neutral. So if you
Yes.
use it judiciously in the Indian variety where we are a little bit of insulinopenic, thin built, this plays a big role. But the thing is, use it properly in the right dose and
Right.
educate them about these symptoms. Find out the reason why that this happened. If there are no reasons, yes, the drug is a culprit. If there are reasons, they are the culprits. Okay. So I think
Absolutely.
this should go because it's a very potent drug. It's a good drug. It continues to be there in our armamentarium.
Absolutely. Dr. Bantwal, thank you for those golden words of wisdom. We will move on to Dr. Kanungo. Dr. Kanungo, your opinion about the case number one in terms of if this was a Modi SU, the use of SUs in this kind of scenario, and
It is
any.
a case of autoimmune diabetes, definitely.
Okay. All right.
Tissue transglutaminase should be tested for this IBS. So
Yes.
after doing that tissue transglutaminase, we can know, pinpoint the cause. And many of the type 1 patients do get autoimmune this tissue transglutaminase positive. As Dr. Bantwal has told, it should be insulin is the primary drug. It is not a case of MODI because they are all requiring insulin. It is an autoimmune diabetes and possibly insulin type 1 diabetes with certain complications. So insulin should continue as he has told. C-peptide, GAD antibody, and other things should be tested. This is a case of autoimmune diabetes. We have to
Great.
see there are some cases of type 2 diabetes who are now autoimmune. So we have to look at autoimmunity angle and focus our treatment as per that. And the father is not there, so family history is not there. So that is against the type 1 that is in favor of type 1 diabetes. So
Absolutely.
if the father is not diabetic and the family history is not strong, it is type 1 goes in favor, but we should look at the irritable bowel syndrome component.
Absolutely. Dr. Pandit, your final words about the case also as well?
A tricky question.
Yes.
I mean, the all four possibilities are possible
Still open.
in the sense that when we're young, every patient who had hypertension, we used to think of pheochromocytoma.
Yes.
But as we age, we understand that it is the essential hypertension which is much, much more common.
Right.
And as the clinical adage goes, that something which is more common occur more commonly. If you think of rare diseases, rarely you will be correct.
True.
So the first thing that I would like to venture upon from the viewpoint of safety is to consider this patient is having type 1 diabetes, put the
Right.
person on insulin, get a good sugar control, do the baseline test and understand whether autoimmune angle is taken care of or not.
Yes.
In this regard, I must say that we have published the autoimmunity in type 1 diabetes from India, the largest study, so to say. This showed that this autoimmune angle cannot be cleared unless and until you do at least 2 or 3 autoimmune markers. Merely with GAD, it cannot be ruled out in every patient.
Yeah.
GAD is positive in around 75%, roughly. So
Right.
another 25% remain where the GAD is negative, but still it is autoimmune. So you'll have to go for some other autoantibody like IAA, like ZNT8 or IA2, etc. And if you do that, if multiple autoantibodies negative, then you are reasonably sure that this is not type 1 diabetes. Now, what
Right.
else is there? So far as commonality is concerned, it can be type 2 diabetes because it is running in the family. You have to, for a moment, you have to forget that the person, his or her, this one, they are, just a minute,
Just
they are having insulin, which may or may not be they are insulinopenic. They may be having type 2 diabetes, put on insulin or whatever. Somebody had thought of type 1, etc., etc.
Sure.
So that way, type 2 diabetes presenting in relatively young age would be my second option. And the
yes.
other 2 options that you need to think of is just because the catch of irritable bowel syndrome, which might mimic a situation of pancreatitis. So pancreatic diabetes is also very possible, especially the person is hailing from either Bengal or Orissa or some of the southern states where it is much more commoner. And many times the pancreatic symptoms are, sort of taken care of as irritable bowel syndrome, which may not be true. It can be jolly well be a celiac disease associated with type 1 diabetes, which is also rather quite common, where
Yes.
it will also mimic irritable bowel syndrome. And the last one, the last bit that you should think about, that it is possible to be MODI, especially MODI 3,
Yes.
because it is relatively early and it is running in the family. Forget about the insulin part. It may or may not have been given to the person in the first place. So it is possible, and there, and moreover, in this particular patient, the hyperglycemia is not severe. It is only 7.4. So this mild degree of hyperglycemia, relatively young onset, it is possible to have MODI, especially MODI
Yeah.
3, not glucokinase 1, MODI 3, and there probably you should like to go for ruling out the possibility with the usage of this genetic analysis, which is
Correct.
possible these days in India. So this would be roughly this one. So first of all, you have to rule out type 1 diabetes. take it as type 2 diabetes, think of pancreatic diabetes, and possibly rule out the rare cause of MODY.
Okay. So again, thank you for the whole comprehensive analysis of the case. Dr. Kanungo, for you, 2 lines on low-dose sulfonylureas, because we'll now look to close the Glow Show in a few minutes. So your 2-liner about low-dose modern-day sulfonylureas.
Patient in front of you and his economic status decides the use of sulfonylurea, that too in a very controlled manner from low to upper end and beyond 2 milligram. If it is not working glimepiride, think of a different drug and add on to that along with metformin. Metformin adequate dose of 2 gram per day should also be included with the glimepiride in whatever dose you give. Then you get the adequate result of that, and beyond that you can think of any other thing, insulin or newer drugs, that is possible. When newer oils came, Bengalis and Odias who love mustard oil, that it was bounced back that mustard oil will kill your heart, you will die. But what is the situation now? For entry of newer products, old products are killed, sabotaged, and that is a pharma mafiagiri that takes place, and this is not the choice. I am a strong supporter of glimepiride and sulfonylureas. For India needs it, Southeast Asia needs it. We cannot
Right.
throw them out just because there may be diamond for somebody, but silver must be there for her leg, fingers, paunji, or whatever that may be. It must be taken, and we should not throw away or blame sulfonylurea for none of their faults. I am a
Right.
strong protagonist of sulfonylurea in low dose.
Right. Excellent. So we've concluded that from Dr. Kanungo that mother's food is best, old is gold, or rather old is silver, and basically the purse strings matter. So the purse matters also as well. Dr. Pandit, your final take, the final words are yours today.
I mean, I would only echo what Dr. Kanungo said.
Yes.
Something which you have been using for so many years, comfortable, have become expert. There is no dire reason to, I mean, just throw them out of the window, just to let some other agents to be let in. This is the standard pharmaceutical industry practice to give old anti-hyperglycemic, anti-hypertensive, or anything a bad name so that the newer ones can gain entry. And as physicians, we must uh, do this uphill task of preventing such actions from the viewpoint of the pharmaceutical industry, and let believe that something which has been used for such a long time have no criminal record, so to say,
Yes.
and you are expert in using this thing, and not for
Yes.
the sake of our expertise, is for the pocket friendliness, which is also important. If you
True.
prescribe something which is not pocket friendly, the patient is not going to follow that one, and obviously he or she will continue to have hyperglycemia for longer duration and will invite all the complications. So I believe we are doing a more disservice to them by prescribing an agent which is not friendly to him or her. So
Absolutely.
so that way, I'm a strong proponent of sulfonylurea,
Yes.
primarily because of its efficacy and relative safety, and most importantly, pocket friendliness.
Absolutely. So I think in conclusion over here, as Dr. Pandit says, you don't need a Mercedes to get you to your destination if the Fiat is doing so. Well, ultimately, we are reaching our goals, and that's what's important for our population, very importantly as well. So I think in conclusion for today's, I don't see any questions in the chat box, but I'd like to say over here in conclusion that today sulfonylureas, when used for the right patient at the right dose, with the right education of physicians and patients alike, well, we have effective use, we have safe use, and we have value for money all as well. Let's forget about the street noise all around, and let's see that we are reaching goal at the end of the day with our sulfonylureas, which all of us have used extensively in practice and still are so comfortable with. I think it is not a drug worth forgetting. Well, with that, I hand it back to Silky. Silky, the floor is yours once again, please.
Thank you so much, ma'am. I must say
Thank you, Pia.
that was indeed an
Thank you. Thank you
insightful
so much, Dr.
feast.
Oh, thank you so much, Dr.
Yeah,
Anders. Thank you.
yeah. I would say starting from the early screening, monitoring, management approaches, prevention of complications, diets, and busting myths about diabetes reversal highlighted the solution to the challenges that every clinician must be facing in their routine clinical practice. I believe every attendee who has tuned into the program shall have several key takeaways for an even better patient care that they are already delivering. And it would definitely help us inch closer to our goal of making India the diabetes care capital of the world. On behalf of Team USP, I would take this opportunity to express my sincere gratitude and thanks to all the delegates who tuned in for this show. Also, my heartfelt thanks to you, Dr. Pia, for making it so engaging, and our expert panelists, Dr. Alok Kanungu, Dr. Ganpati Bandwal, and Dr. Kaushik Pandit. Thanks to you, sirs, for sharing your clinical wisdom with all of us. And thank you all for taking out time and joining us here. I wish everyone a good evening ahead. Thank you, everyone.
Thank you to the
Thank
excellent
you.
panelists, our glowing panelists for the glowing show. Thank you so
Thank
much.
you very much.
Thank
Thank you,
you.
ma'am.
Thank you.
Thank you, Silky.
Good night.
Thank you, sir.